school. I think most of my interest was in things like math and physics and chemistry, that sort of thing. But then came World War II, and I ended up as a bombardier navigator on a A-26 in European theater, and that sort of changes your approach to a lot of things. Probably decided to go into medicine, seeing people who were in automobile accidents and how long it took to get a lot of their injuries healed. But I don't think I really had any great feeling about medicine up until that time. My brother was in the hospital with well, actually a severe fracture of his femur. And so he was in for almost 2 years just with a fractured leg. I started to practice when I got to, I would say I was actually practicing when I was a resident in Milwaukee and also in Boston. And as far as choosing a specialty, I think when I finished general surgery residency, I felt that there was a little more I wanted to look into. I couldn't feel that the diaphragm should keep you from doing what's the next best thing to do. As far as a typical day when you start practicing...
Oh, could you just quickly state where you went to medical school?
Yeah? Oh,
where did you go to medical school?
University of Wisconsin.
Right. And when did you graduate?
In I graduated in 1952.
Okay. Yeah, so what brought you to Worcester exactly? Where did you go?
Well, when I finished my general surgical residency in Milwaukee, I wanted to do more, so I applied for the thoracic surgery residency at Boston City, which was the only one in the whole state of Massachusetts at that time. And that's what brought me out here, and I probably would have gone right back if it hadn't been for the thoracic surgeon here who wanted me to help me get a open heart program started.
And that was in Worcester, right?
And so that's basically where we started in my, the way the practice begins is where do you get your patients? So if you've got a consultation request in for you, that's probably your first typical day is an atypical day.
Okay.
As far as hours are concerned, it's difficult to straighten that out. You sort of do what is necessary, and then when you don't have to work anymore, then you go home. And
how early did you start in the morning?
Huh?
How early did you start in the morning?
Well, it depends on what's in the hospital. It depends on who you're seeing. It depends on whether you were called out in the middle of the night for an automobile accident, gunshot wound, stab wound, that sort of thing. And or if the residents called you in and said, we have something new in the emergency room, or we don't, we've got a patient upstairs who's not looking well. That would bring you in a little earlier. I don't think there was any one set time. You couldn't say that you're always going to be there at 7 o'clock. It could be 4 o'clock, it could be 9 o'clock. You asked, do you make house calls? I think the only house calls that you make when you're in an active practice is patients that you've known from other background and who can't actually come to your office. And I don't think, as thoracic surgeons are concerned, you probably will see very many people who can't come in to see you in the office or in the hospital. So that the house calls that you make are very special.
Did you ever use the telephone to talk with patients?
I would think that most of your discussion with your patients is going to be one-on-one, because you can't make a diagnosis, you can't make any decision without talking to the patient. And so I'd say, I would say very few telephone conversations with thoracic surgeons.
Okay. So you were at the hospital most of your time, right? All of your time?
Yes, and when we started in practice in Worcester, that meant Worcester County, so that we saw patients in all of the hospitals in town.
Oh, okay.
And so starting, you could start at Holden, Fairlawn, City Hospital, St. Vincent Hospital, Memorial Hospital.
Wow.
Then you could keep on going. We would see consults as far away as Natick, and sometimes these were consults that really needed to be admitted to the hospital, but the referring physician wanted you to see the patient before you transferred the patient.
So would you travel between these hospitals in one day? Or do you
Every day.
Would you care to describe more about your rounds in the hospital and more about what your typical day was like?
Well, again, I think first thing in the morning, if things are stable, you'd go to the operating room and get that out of the way.
Mm-hmm.
And then following surgery, then you could go and do ward rounds. And again, it depends on what kind of patients you're seeing and how much of your attention they need.
And most of your patients were from around the Worcester area, right?
Most of the patients were from Worcester County. As I say, it depends on when I first started in, Dr. Ware and I were doing cases, I think, on Wednesday at the Worcester County Sanatorium, and that continued for some time. So it seemed like that was Wednesday surgery, was Wednesday afternoon was surgery at the county hospital.
How many patients would you have in the hospital at any one time?
Cleo, here. Come here. Sit. I think it varied, but I can tell you could usually fill up both sides of a 8.5 by 11
Wow.
paper. And I would say you might, in your busy hospitals, you might see 10 or 15 patients, and then at other hospitals you might see 1 or 2. Or you may go and see the consults first and then make rounds on those patients.
What do you think it was like for your family to have a physician in the household?
What did I think of?
Your family. What do you think it was like for them to have a physician in the household?
I don't think that's anything that they made any great differentiation. I mean, somebody's a doctor, another one's a plumber, another's. I mean, I don't think it made an awful lot of difference with the family. I think my wife and I realized we didn't have as much free time for each other as we'd like, but we had a good time.
Did you get to see your family often, or were you working long hours usually?
Well, as much as we could. And I don't think anybody sat around saying, you know, we don't see you enough, that sort of thing, because it was one of those situations where they could be all set to go to the beach, and that was when I was on call for myself. Kids were all ready to go to the beach, and the phone rang, and we had an emergency at the Hahnemann Hospital or Memorial Hospital, and Mary would say, "All right, everybody out of the bus," because we only had one car. And There was very little grumbling. I think they sort of got used to that after a while. And so no one was whining or crying. We were all set to go, and look what happened. And from that standpoint, it worked out. I think I have to give my wife credit for that. She did not make a doctor being anything super special. Cleo, come here. Here.
Did you take vacations during your practice?
I take what?
Vacations?
Whenever we could. Whenever we could. Most of it had to do with coverage. And since there were only 3 of us in town, it was difficult for more than one of us to be away at the same time. But I would say we did the best we could, and I think our kids were young, and so they had a great mother, so that they were not unhappy about the world.
So what did you really like about your practice as a surgeon? What made you keep being a doctor for so long?
I think it's what I enjoyed about my practice is pretty much what anyone enjoys about whatever they do. If you enjoy being a plumber, then you're doing the right thing. If you don't enjoy being an electrician, then you're doing the wrong thing. And so from the standpoint of, if you like medicine, why change? No, it was, I had a very pleasant practice from beginning to end. I only had 1 malpractice suit, and that was a sort of I think it was an attempt to make money by the plaintiff, and it took 9 years, and a lot of specialists, and the bottom line was the jury and the judge threw it out after 9 years of nuisance. So I would say that it shows you how much time you can waste. I think we probably rescheduled that, probably 8 to 10 times. One time their specialist was vacationing in England, and one time one of their girls was getting married, and it was the last time that they set it up was just, I think, 8 days after my wife had passed on. And I thought that was a little bit bush, but I'm surely not going to cancel that out for something that, and most of the cancellations were done by the adversary, so that there's nothing you can do about that.
Did the malpractice suit affect you a great deal in terms of the decisions you made in your career later on, or
I mean, these people were money hungry, and there were lawyers in the family, and so it probably did not cost as much to get a lawyer on your side. But I think when you see this for what it was, I think malpractice is probably not a very good term anyway. I mean, if you had someone who was guilty of malpractice, then you wouldn't have to go to court, would you?
What were the most typical illnesses that you dealt with early in your career?
Most typical.
Right.
Probably the most common would be a pulmonary disease, and by far the greatest was the carcinoma of the lung. And there were lots of smokers in the Worcester area, and so that was probably the most common illness that we saw in surgery. The rest of them would be septic conditions like empyemas and bronchiectasis, that sort of thing. And Then trauma was, again, probably one of the most active after you have gotten rid of the lung cancer group. Automobile accidents, gunshot wounds, stab wounds, that sort of thing.
And in subsequent decades, did the illnesses that you saw change at all? Or were they pretty much the same?
Oh yeah, quite a bit, because when we first came to town, each one of the hospitals in town had a very large pediatric department. St. Vincent's, as a matter of fact, the seventh floor was all pediatrics. City Hospital, the same thing. Memorial Hospital, a floor on the, and most of these were things like pneumonia, croup. We used to do a lot of emergency tracheotomies on kids who could not breathe on their own. And if you look at that group of patients, the entire pediatric wards were solid full. And now you go into the same hospital and you'll find that there's no large amount of pediatric patients in the same, and most of it has to do with sepsis and viral infections.
What was the greatest challenge for you to treat when you started practicing medicine? Was it the carcinoma that you said you saw?
Well, I think if you felt that you were capable, there weren't very many things that, you know, if you're well trained and you don't look at anything, you look at every patient as a challenge. Okay. And so it's not what is the most challenging thing today. Every patient is, and you can't get too complacent, because some very good doctors make mistakes. And so you want to be aware of what the pitfalls are.
What was one of the most important breakthroughs in disease treatment during the course of your practice? What do you...
I would probably say lung cancer, because it's something that, when I was an intern in California, we saw two problems of lung cancer, and one was on the neurosurgical service with a metastasis to the brain, and the other one was on the orthopedic service with metastasis to a bone. And once I got to Worcester, we were seeing the beginning of an epidemic of lung cancer, and everybody that you walked by in the street was smoking.
Right. And so you think that we've broken through in that field, that's no longer as much of a problem?
Oh, it's still a problem, and there are still people who continue to smoke. But I don't think you see nearly as much now as you did before. It used to be everybody who went out in the car would light up and have a cigarette, and if they went out to dinner, they would smoke after dinner, before dinner, have a cocktail, smoke. I think a lot of that is true. I think one of the other big problems that goes with that is that smoking and drinking seem to go together, and we still have the problems with smoking, and we still have the problem with alcoholism, and probably one of the big tragedies are smoking and drinking, because both of them can be solved by a good decision by the patient, yet they still continue to commit suicide.
What did you see as one of the most important breakthroughs in disease prevention during the course of your career?
Well, I would say probably education in general, but I think that if you took hand washing and what it has done in the hospital and out of the hospital, it has to have made a pretty good impetus on, or I should say, a pretty good preventative measure. And I think, when you think of what has gone on in the blood products, transfusions, that sort of thing. I mean, we have gone so far, because when I was in high school, if you were O negative, you were the universal donor. If you were AB negative, you were the universal recipient. And having given a unit of blood when I was a high school senior, a lot of things that we have learned about blood since then is amazing. And just think of what we know about AIDS that we wouldn't know if we didn't know blood and transfusions.
In terms of technology, what do you think? What do you think is something that doctors take for granted now that you'd have back when you started practicing medicine?
Communication.
What kind of? What do you mean by that?
Well, Cleo, come here. If you have a patient by the side of the road and he's bleeding to death, back in the good old days you would put a tourniquet on if there was an extremity and throw him in the back seat and head for the nearest hospital. Now you can pick up the phone and you can talk to specialists throughout the entire world and say, well, how did your last craniotomy go? You know, I'm joking, but communication has changed so much. And so now, if you're in the operating room and you look at something and you don't recognize it, you can call your friend Barney, who works out of the Mount Sinai Hospital in San Francisco, and say, Barney, remember that story you told us about the patient? And there is the communication that you have no way of getting 20, 30 years ago. And so I think that probably has done more than almost anything. I mean, there's no magic drug that we have yet. And I think everything is better, but I think communication is very hard to beat. I mean, if you have a problem and you don't have communication, you've really got a problem.
What technology is still in use today in your field, or generally in medicine, that was used really when you were in medical school?
A good history and a good physical examination is hard to beat. Okay. And if you don't do a good history, don't do a good physical examination, you don't even know what's wrong with the patient, and you have no idea of coming up with the answer.
Describe one important invention that you've seen, one important piece of technology that you've seen invented during the course of your career, and tell me when it was first used.
Oh, I think open heart surgery probably was one of the biggest breakthroughs that we've seen in surgery itself. Yep. And when you think of people like C. Walton Lillehei, who I remember when talking about 1960, 62, would be just doing phenomenal surgery, and they were doing it because of a good extracorporeal setup and understanding the physiology of blood transport. But I think the fact that now with that sort of vascular approach, there's some things that can be done today that could not be done back in the 60s.
Is there anything that you would like to see invented in the medical field?
Invented in the medical field.
A piece of technology, or I don't know, anything.
Um, well, I think there are so many tragedies in the world that you know, you could pick any one of them. I think that if we could wipe out AIDS, for example, that would be a phenomenal piece of magic. I mean, we know what causes it, but we don't know how to really control it. And you think of the poor people in Africa and the poor, well, almost all third world countries have it, but Africa is just rent with the, so I think it's things that, like that still need help.
Do you think we're on the right track to solving those problems? Do you think there will be a cure for AIDS or cancer?
Do you think we'll have solutions to the problems?
Yeah, and how soon do you think?
Well, I don't think you can. I think it will depend on the interest of the people who are looking at this from a investigation standpoint. I think we've got some brilliant students today that are so much brighter than we were when we were in the same era. And there's no question in my mind that since these are smarter people, they're going to be doing more things. And when you see what happens in the fields here, I think to go back a couple of steps would be to, if you really wanted things to be better, then I think you have to go back to the fundamentals like honesty and doing things that are good as against things that are bad. And well, when you see what the world is into now, I think we have lots of problems that we still have to solve. And medicine's not going to help all of them. It'll be interesting to see how the World War comes out. But also, when you think of what's recently happened with the economy and the dishonesty and the actually outright stealing of things, it just, you know, it makes you wonder, are we heading in the right direction? Oh, you are heading in the right direction, yes. Asking a surgeon to discuss drugs is probably a little inappropriate because most surgeons do most of their... Shut it off for just a second. Well, in asking a surgeon about medicines is a little bit inappropriate because most surgeons feel that it's their technique that's more important than any ancillary drugs. However, I think from a practical standpoint, there are some drugs that we used in surgery a good deal, and mostly that was those to relieve pain. And the antibiotics that are necessary in long operations, and I think when you think about the fact that we're fighting to get new drugs over and over and over again in the antibiotic field, for example, you wonder if we should not have been more stringent as giving out the new drug so that the bacteria become resistant to the new drug when they still are receptive to the drugs that have passed in the previous era. So, with the exception of specialties like the endocrine system, In surgery, pain medicine, antibiotics are so necessary. The I think we don't have as many big things like the treatment of tuberculosis. Now, when I started out as a thoracic surgery resident, operating on 7 patients with tuberculosis of the lung in Boston City Hospital every week. And now you see very little, but unfortunately we're seeing tuberculosis coming back in the transportation of people who come from other countries, so that it's not going to we cured once, why do we have to cure it again? Because it's still there, and they're in the third world countries, and it's those in any of the impoverished areas. I do think that we may have made some mistake by getting rid of the drug salesman,
Yes.
because if a physician is very busy and does not have a chance to confer his confreres along, and this is true not only in surgery and medicine, but also in the general practitioner who is seeing more patients than he should have to, but he's so busy he has to take care of those who come, that it was nice for the general practitioner to sit down and talk about the real world with the drug salesman, just to see what's going on. And there's no question about it that if the drug salesman is dishonest, it does not take a general practitioner long to realize that and say, that's not what I need. But as I say, it did educate some of the people in general medicine that probably would not even seen these people because he would be too busy and he would slam the door in their face. I think we've lost some of the benefit of a consultant, call him a pharmacological salesman. But if you see some drugs that are presented to the medical field today, and some that have no reason for being except for the fact that they're pushed by a large drug company, because a lot of those are discontinued and end up not being as useful as we thought they were. So I think we lose that. And the other is, I think the cost is just out of sight. But I think if we'd done what we talked about before, use the drugs that are worthwhile, and then if a new one comes along, limit its use to the very ill that do not respond to the drugs that have previously been useful. And I think you're at least, you may not be making as much spendable money, but you sure are giving the next patient who comes into your office a better chance of a recovery with a new #1 drug that has not been overused.
Would you like to move on now?
Sure.
All right. Do you think that? Well, how did patients without money receive health care early in their career?
How do patients? How did they receive health care without any money?
Yeah.
Okay. Well, I think they went to their doctor. And they went to their doctor, and their doctor did a history and a physical and got the right lab work and things like that, and took care of them. And the average doctor would send him a bill, and if he did not have any money, the average doctor would have to just accept this as a charitable use. And I remember my secretary, who was German, she liked to keep an eye on money. Every month she would bring in a list of people who could not pay for their surgery or could not pay for this or could not. And we would just write those off as charity, because if you don't have any money, you can't pay anybody. And how foolish it would be to sue someone for money when they don't have any.
Yeah.
And so I think that's part of it. I think the medicine probably was a little more friendly then. I would say medicine, the field of medicine was more friendly then. And well, look at what has happened in the last 25 years when the hospitals were going into the doctor business and the HMOs and all of that. And so the doctor, even if he wanted to give a charitable donation to a patient who didn't have any money, he was not allowed to because he couldn't bill, because his employer was doing the billing. And I think that's, from what I see across the country today, I think we're going back to the old fee-for-service principle, because it works. And I think if you look around in Worcester, you'll find there are certain groups of physicians who have banded together and do private practice, fee-for-service, like we always used to.
Okay. Over the years, how do you think Worcester has compared to other places in terms of providing care for the underserved? Could you really make a comparison between Worcester and other places?
Well, I think when you've got certain rules, I think Worcester has done very well, generally speaking, through the years, but that has changed a good deal also, because at one time all you had to do was show up at City Hospital and you got care whether you had money or not. And if you went to Memorial Hospital, they were receiving, let's say, 25% subsidy to no-pay patients. And that was true of almost all of the active hospitals at that time. But I think everyone cannot have money, because there's always going to be somebody who's poor and somebody who's rich. But you have to have some way of giving them some recompense to take care of a health problem that they have no choice but to have to go for care. I think it's unfortunate that people get sick, but it doesn't seem right that they should be penalized with a big medical bill just because they've been sick.
What were some fears and concerns about socialized medicine in the 50s and 60s, or the late 50s?
I think the main concern was the fact that the doctor used to make the medical decisions, and when the doctor is not able to make the medical decisions, then his employer, or whoever signs his check, will tell him how much time he should spend with Mr. Smith and Mr. Jones and that heavy-set lady from the other side of the tracks. And I think that's unfair, again, to somebody who's sick, to now you're not going to give them any charitable help, and at the same time you're going to tie the doctor's hands behind him because he can't do a good history and physical because you're only allotting him 12.5 minutes per patient. And if you don't see, if you don't put in something like 38 patient contacts in a 3-day period, you'll get penalized by your employer. I mean, it doesn't make any sense, does it? Because you can't make the right diagnosis with a 4-minute history and physical, and there's no reason why you should be asked to. So, not a good means of handling medical problems.
Were physicians ever involved politically on the topic of socialized medicine? Not necessarily you, but others that you knew.
I think I'm probably the wrong person to ask that question because I was busy taking care of patients, and I think it's probably what everybody else was doing. They were busy taking care of patients, and so could not really come up with any strong defense against, quote, socialized medicine until it was already there. And then it became a who has the referral practice, and if no one is going to send you any patients, you can't be a very busy doctor, then you have to either move out or join the group. So I think that it happened. It was unfortunate that the physicians did not band together and present a strong focus against socialized medicine. But I think that's not what doctors are. Doctors like independent thinking, and if you're not going to let your doctors make an independent decision, then is he the one that you want to go see about your big mass in the left abdomen or the headaches that won't go away? So I think it probably was too bad that the physicians did not get involved. But again, if you're busy, you do what you are doing, and then some very shrewd people can come in and they can buy up a group of referring type doctors, and then you can get those referring type doctors to only consult those people who are on your salaried staff. Does that make sense?
Yeah.
So once you have lost the referral pool, you are all alone with no patients. And you can have the best ethics, the best honesty, actually the best technique in the world, but who's going to send you a patient? And then where are you going to hospitalize them? Well, the hospital won't let you.
Okay. What were your feelings on Medicare and Medicaid when they came in the 60s?
I think it was a Medicare and Medicaid, I think, represented an attempt to resist the kind of HMO medicine that we're seeing. And why? Because some people are poor, and some people are old, and some are infirm, and some are very sick. And they have to be supported in some fashion. And so if you've got someone who does not have the funds to pay for their care, then the government has to step in and help. And I think that's the only reason that they do that. And again, I think it probably was dropped by the medical profession, but all by the legislature, or call them what you like. But I don't think that the government was, I think it's too little too late again. I think when you see it today,